Hello everyone, let's cover in this video the Thyroid Bethesda System of Reporting, which is a very common cytological practice, but I'll cover it from the more clinical or surgical aspect rather than the cytological features of this system. So starting with the system, it has actually six categories. Bethesda 1 is unsatisfactory or non-diagnostic. 2 is benign. 3 is AUS, ATP of undetermined significance. 4 is suspicious for follicular neoplasm or follicular neoplasm. 5 is suspicious for malignancy, and 6 is malignant. So with Bethesda 1, the unsatisfactory, the non-diagnostic, the risk of malignancy is about 5 to 10%. It's managed by repeating the FNA with ultrasound guidance, basically. In this category, you have the specimens that do not meet the criteria of adequacy, like when you have less than 6 follicles or less than 6 groups with 10 follicular cells, unless if you have a pathology or the ATPSC in there, or when you have thick colloid. In these cases, we wouldn't call it unsatisfactory. Moving to the benign, which has a risk of malignancy of less than 3%, and it's managed by clinical and sonographic follow-up. Then category 3 is ATP of undetermined significance. It has a risk of malignancy of 6 to 18%. It's managed by repeating FNA, molecular testing, or lobectomy. And mentioning molecular testing, like the most common associated molecular mutations seen in papillary thyroid carcinoma are BRAF, RAS, also there's RET, NTERC, ALK, and others. They are all tested molecularly. Then category 4 is suspicious for follicular neoplasm or follicular neoplasm. Here the risk of malignancy increases to 10 to 40%, and it's managed by molecular testing or lobectomy. And a colleague of mine told me, when you call a tumor suspicious on cytology, it means that they will put the patient on the table actually. So they will do the surgery. Category 5 is suspicious for malignancy, and in this category, you have 45 to 60% of risk of malignancy, and it's managed by near total thyroidectomy or lobectomy. Actually, most of the cases they are managed with a total thyroidectomy. Finally, the category of malignant, which has a risk of malignancy of 94 to 96%, and actually this risk increases to 99% if we consider NEF-TIP as a malignant or as a cancer. And in these cases, also the management would be near total thyroidectomy or lobectomy, but definitely the patient will undergo the surgery in these cases. I'll leave you with this table that I took from this very good cytology book. It summarizes the findings that I have just discussed.